think it worked. Okay, great. And I'm going to hand things over to Caroline, who's going to take over for presenting today on our recent preliminary data that we just submitted for publication. I'll hand it over to you, Caroline.
Amazing. I'll go ahead and share my screen.
And Caroline, I'm going to put your bio in the chat, but feel free to just take a minute to introduce yourself and kind of where you're at and all the exciting things that you're up to so people have a little bit idea who you are.
Yeah, absolutely. So thank you so much, Dr. Martin, and thank you all so much for having me speak today. So my name is Caroline. I'm an MD MPH student at WashU in St. Louis, and I'm currently in my MPH year. And I've had the honor of getting to work with a really amazing team of OBGYN and addiction medicine experts, including my PIs, Dr. Martin and Dr. Shu, on our project on alcohol use disorder and pregnancy over the past few months. And I'm really excited to get to share our results with you. And this study, which we recently submitted to AJOG, is entitled Screen and Say Just Don't Drink, a systematic review of international guidelines for addressing alcohol use and treating alcohol use disorder in pregnancy. So before I dive into the details, I'll give you a quick overview of what I'll cover today. I'll start with some background on alcohol use and alcohol use disorder in pregnancy, then discuss what we set out to accomplish with our study. I'll delve into our approach for the systematic review, and then I'll describe the recommendations we found within the clinical practice guidelines that we examined. And lastly, I'll discuss the implications of our findings on clinical practice. So, alcohol use disorder, or AUD, is the most common substance use disorder in the United States and worldwide. Alcohol use in pregnancy is widespread, with a global prevalence of about 10%, and English-speaking countries in particular report really high rates, as you can see in the graph on the left, which are from a 2017 meta-analysis, which found that prenatal alcohol use was as prevalent as 41% in the United Kingdom, 36% in Australia, 27% in New Zealand, 15% in the United States, and 10% in Canada. And in the US, rates of prenatal alcohol use and binge drinking have been rising. And per preliminary NIH HBCD data, which is shown in the graph on the right here, alcohol is the most common prenatal substance exposure in the United States, overtaking cannabis, tobacco, and opioids. The health impacts of alcohol use are well established. Alcohol use disorder in particular carries serious risks from premature mortality to chronic conditions. And when alcohol is used during pregnancy, its effects on both the parent and the fetus are widely recognized and extensively documented. It can lead to severe maternal morbidity, spontaneous abortion, stillbirth, and intrauterine growth restriction. And importantly, it can also result in fetal alcohol spectrum disorder, which is a condition associated with neurodevelopmental impairment, congenital anomalies, poor growth, and additional cardiovascular, GI, and mental health comorbidities. So to illustrate how the risks of alcohol use during pregnancy are typically communicated to patients, I've included this infographic from the American College of Obstetricians and Gynecologists. And as you can see, the main message here is kind of emphasizing that drinking during pregnancy can have serious and potentially devastating effects on fetal development, which are outlined in the graphic. So this is the final section of that ACOG flyer. It states that alcohol-related birth defects are completely preventable. And while this is biologically true, alcohol exposure can be avoided, this wording doesn't fully acknowledge the challenges many people face in reducing or stopping alcohol use during pregnancy. And while the flyer emphasizes that these outcomes are preventable, it provides very little concrete guidance for individuals who may struggle to stop drinking during pregnancy, beyond suggesting that they speak to their OB, attend AA, or call the SAMHSA treatment referral line. As we'll discuss, this misalignment between strong abstinence counseling and few treatment options is quite common. So, given what we know about the effects of alcohol use in pregnancy, the question becomes, how do we address it? As suggested by the lack of guidance in the previous slide, there's limited evidence to inform clinical decision-making for alcohol use disorder during pregnancy, despite the substantial disease burden. And this is reflected in treatment patterns. Most pregnant patients with alcohol use disorder in the US and Australia, for example, don't receive medication for alcohol use disorder, or MAUD. Treating alcohol use disorder in pregnancy isn't straightforward and comes with a set of unique clinical considerations. MAUD such as acamprosate and naltrexone, are effective and well tolerated in the general adult population. However, their safety and effectiveness in pregnancy are largely unknown, and strategies for balancing maternal benefit with fetal risk are poorly characterized. As such, for pregnant people who are on MAUD when they become pregnant, discontinuation often occurs during the first trimester. And the effects of discontinuing MAUD in pregnancy isn't something that we really have a firm understanding of. So let's say a pregnant person with alcohol use disorder stops drinking. What happens next? When people stop drinking during pregnancy, there are still hurdles to cross. During early recovery, especially, patients often face a range of mental health challenges, things like emotional dysregulation, anxiety, depressive symptoms. And because access to perinatal mental health specialists is often very limited, much of this care typically falls to OBGYNs. So clearly, alcohol use disorder and alcohol use in pregnancy are complex issues that require specialized coordinated care. So this takes us to the objective of our study. We set out to take a closer look at major clinical practice guidelines, which I'll refer to as CPGs, from around the world. And we wanted to see how they address alcohol use and alcohol use disorder during pregnancy, especially the use of medications for alcohol use disorder. We used the alcohol use disorder cascade of care framework to guide our review, looking at how these guidelines offered recommendations across key stages of treatment, specifically diagnosis, engagement, initiation, and retention. So, next, I'll talk about how we approached the study. We used the PICAR framework to structure our review of clinical practice guidelines. Our population included pregnant people who use alcohol or who have an alcohol use disorder. And we looked at interventions for alcohol use disorder, including medications, psychosocial approaches, screening, and brief interventions, both with or without a comparator. And in terms of the content we were looking for, we focused on guidelines from professional medical organizations from primarily English speaking countries, that were published since 2014 that addressed alcohol use disorder treatment during pregnancy. And for each eligible guideline, we examined its attributes and recommendations, looking at whether and how it provided guidance on screening, managing, or treating alcohol use disorder in pregnancy. So here's how we identified and selected the guidelines. First, we searched PubMed and major guideline databases using terms related to substance use, alcohol use disorder, pregnancy, and clinical practice guidelines. Two reviewers screened the abstracts and covidence, and we included full text if they focused on substance use or mental health and pregnancy, and were meant for clinicians who care for pregnant patients. And then in a second phase, we searched gray literature like professional society and government health department websites to capture any additional guidelines. For data extraction, we recorded each guideline's characteristics, focus, and any recommendations on alcohol use disorder treatment in pregnancy. And then we used the AgreeRex framework to assess the quality of the recommendations, essentially looking at how clear, relevant, and actionable each one of them were. So that's how we identified, extracted, and assessed the guidelines in our review. To give you a visual overview of that process, this next slide shows our PRISMA diagram. In phase one, our search of PubMed and major guideline databases yielded 829 records, and after removing duplicates and screening abstracts in covidence, we ended up reviewing 32 full-text articles. These focused on substance use or mental health in pregnancy and were intended for clinicians caring for pregnant patients. And then in phase two, our gray literature search added an additional 216 records for review. And after completing both of these phases, we had a total of 18 clinical practice guidelines that met our inclusion criteria and were included in the analysis. So this table summarizes the 18 guidelines that we reviewed. Many, 8 came from the US, with others from Australia and New Zealand, Canada, the United Kingdom, and international organizations like the World Health Organization. And they all targeted a mix of specialties from general practice and psychiatry to OBGYN, addiction medicine, and family medicine. So now I'm going to move into what these 18 clinical practice guidelines actually said about alcohol use and alcohol use disorder in pregnancy. And I've organized the findings according to the stages of the care cascade. So I'll go through each stage one by one, and then at the end I'll show a slide that kind of brings them all together side by side. And I'm going to start by discussing their general approach to alcohol use in pregnancy. Nearly all the guidelines, all but one, discuss the risks of alcohol exposure during pregnancy. Similarly, almost all, except for two, recommended counseling pregnant patients on alcohol cessation. And about 72% of the guidelines specifically mentioned screening pregnant patients for alcohol use. So, in general, these were pretty well represented among the 18 that we looked at. Next, looking at how the guidelines address clinical management of alcohol use during pregnancy, about 61% of the guidelines mentioned referring pregnant patients to some form of treatment for alcohol use. A third of the guidelines included any discussion of harm reduction, such as strategies for reducing alcohol use during pregnancy, and half provided guidance on treating alcohol withdrawal with medication during pregnancy. So clearly, the stage of the cascade is not as well represented among the guidelines as the earlier stages, like describing the risks of alcohol use in pregnancy, screening, and counseling for cessation. Next, we looked at how these guidelines define and conceptualize alcohol use disorder, because clear terminology is important as it influences how clinicians approach diagnosis and treatment for alcohol use disorder during pregnancy. So, just over half, about 56%, explicitly use the term alcohol use disorder at least once, rather than only referring to alcohol use or people who use alcohol. And about 39% of the guidelines clearly distinguished between treating alcohol use disorder and treating alcohol use that doesn't meet diagnostic criteria for a substance use disorder. So, once again, not as well represented as the first stage in the care cascade. And lastly, we looked at the specific recommendations that these guidelines made for treating alcohol use disorder during pregnancy. Fewer than half, about 44%, mentioned the use of medications for alcohol use disorder during pregnancy, and only half of those went on to provide an actual recommendation for or against their use. Of those, three guidelines actively recommended against using medication for alcohol use disorder in pregnancy, while only one explicitly supported it. In addition, just three guidelines mention any form of psychosocial intervention for alcohol use disorder during pregnancy. And as you can see, this stage of the care cascade was the least represented of the four. So we've now walked through how these 18 guidelines addressed alcohol use and alcohol use disorder in pregnancy step by step across each stage of the care cascade. And on this slide, I've pulled together all the pieces so you can see the full picture side by side. So this helps highlight where the strongest guidance exists, which is towards the beginning of the cascade, and where the gaps start to emerge further along the cascade towards treatment. Now that we've looked at the overall patterns across the cascade, I am going to show a few kind of representative excerpts from the small number of guidelines that explicitly addressed medication for alcohol use disorder in pregnancy to illustrate how they approached this issue in their own language. So here are a couple of representative quotes from the four guidelines that addressed medication for alcohol use disorder during pregnancy and took a fairly equivocal stance. Several, like the World Health Organization and the National Drug and Alcohol Research Center guidelines, acknowledge that medications like disulfiram, naltrexone, and acamprosate exist, but they emphasize that their safety and their efficacy haven't really been established for use during pregnancy. So overall, the general message from these CPGs was that decisions should be made on a case-by-case basis and weighing potential risks and benefits for each patient. In contrast to the guidelines that were more neutral, three guidelines explicitly recommended against using medication for alcohol use disorder during pregnancy. The Joint International Guideline from the World Federation of Societies of Biological Psychiatry and the International Association for Women's Mental Health stated that due to the low level of evidence and an unfavorable risk benefit ratio, pharmacologic treatment for maintaining abstinence shouldn't be used during pregnancy. And similarly, the American Psychiatric Association guideline noted that because of limited data on potential fetal risks, non pharmacologic intervention should be used preferentially for treating alcohol use disorder during pregnancy. Finally, the only guideline that offered supportive language around using medication for alcohol use disorder in pregnancy came from the Society of Obstetricians and Gynecologists of Canada. This guideline cited emerging evidence from opioid use disorder treatment, suggesting that naltrexone may be safe in pregnancy and advised prescribing it only when the potential benefits outweigh the risks. Similarly, it noted preliminary evidence for a camprosate's safety in pregnancy with the same kind of cautious recommendation to use it only if the expected benefit outweighs possible risk. So, overall, this was the only guideline that offered any positive recommendation for pharmacologic treatment during pregnancy, while most others either avoided a recommendation or actively advised against use. So, to summarize, there's a lot of guidance around alcohol use in pregnancy itself, with nearly every guideline advising screening all pregnant patients and counseling them not to drink. Some even offered detailed instructions, such as repeated inquiries about alcohol use throughout pregnancy or using validated tools like the audit. But when it came to alcohol use disorder, the guidance really dropped off. Most CPGs stopped at suggesting a referral to specialty care or managing acute withdrawal with very, very little direction on how to actually treat alcohol use disorder during pregnancy. And this pattern was not specific to one specialty. It exists across specialties, including OBGYN, psychiatry, and addiction medicine, despite the expectation that different disciplines might provide a more balanced distribution of recommendations across the treatment cascade. And this pattern, in which each specialty is deferring treatment to others without providing clear management guidelines, likely contributes to the low rates of alcohol use disorder treatment during pregnancy. It's also worth noting that most studies not only avoided discussing medications for alcohol use disorder, but also few mentioned specific psychosocial interventions. And when guidelines did provide recommendations on psychosocial treatment, they're often very general, rarely specifying treatment modalities like cognitive behavioral therapy, motivational enhancement therapy, or 12-step facilitation. They also didn't provide guidance on treatment settings, so whether therapy should be individual or group based, what the session frequency should be, how long treatment duration should be, or kind of any adaptations for pregnancy specific concerns. And importantly, no guideline addressed whether trauma informed approaches should be incorporated or provided direction on the role of mutual help groups like Alcoholics Anonymous during the perinatal period. In terms of strengths and limitations, I'll start by emphasizing that the absence of treatment recommendations and many of these guidelines doesn't necessarily mean that the guidelines were low quality. In fact, most of the clinical practice guidelines scored quite well on dimensions like applicability, values and preferences, and feasibility. So they're actually quite strong in terms of structure and relevance. And the real issue seems to lie in the evidence base itself. There simply isn't enough high quality data to support more definitive recommendations for treating alcohol use disorder during pregnancy, which makes it difficult for organizations to take a stronger stance. As for limitations of our own review, we only included English language guidelines from predominantly English speaking countries. But that said, it's worth noting that the WHO guidelines are designed to be globally applicable, and many nations without extensive national guideline infrastructure, including those that have high rates of perinatal alcohol use, like Brazil, for example, rely heavily on World Health Organization recommendations as the foundation for their national policies and their clinical protocols. So while our review primarily captures guidance from high-income English-speaking nations, the gaps we identified in WHO guidance really do have implications that extend far beyond those populations. And finally, our focus was specifically on pregnancy, not the postpartum period, which is another key window for addressing alcohol use and supporting relapse prevention. So, what really stood out to us is that most of these guidelines do acknowledge just how limited the evidence base is when it comes to using medications for alcohol use disorder during pregnancy. And because of that, they often recommend individualized decision making rather than firm or directive guidance. However, most of these guidelines don't provide parallel discussion of the very well documented and severe risks of untreated alcohol use disorder, both for the pregnant person and for the fetus. No guideline we looked at offered a detailed framework for how to actually weigh the uncertain risks of continuing medication for alcohol use disorder during pregnancy against the known substantial harms of untreated alcohol use disorder during pregnancy. So, in practice, this uncertainty leaves both patients and clinicians facing some really difficult choices. For people with alcohol use disorder who are planning a pregnancy, there's a constant weighing of risks: the risk of continuing medication versus the risk of stopping it. Many patients end up discontinuing psychotropic medications during pregnancy out of concern for fetal exposure, but it's worth noting that in other chronic conditions, through shared decision making, patients often do remain on medications with known fetal risks. For instance, antidepressants or opioid use disorder medications, when the maternal benefits are considered to outweigh potential harms. By contrast, current guidance on alcohol use disorder in pregnancy offers very limited support for similar shared decision making approaches. This leaves clinicians without a clear framework for balancing maternal benefit against possible fetal risk. And while the data that we do have for medications for alcohol use disorder, specifically naltrexone and acamprosate, don't show evidence of harm, it's still a pretty under researched area. Meanwhile, the harms of untreated alcohol use disorder, both for the parent and infant, are very well established. So, altogether, this really underscores the need for more research and clearer evidence informed guidance going forward. So, stepping back, what we found is that there's a clear misalignment in this space. On one hand, there's a strong consensus. Nearly every guideline emphasizes the importance of universal alcohol screening and counseling for abstinence during pregnancy. And as I mentioned earlier, these guidelines are generally rigorous and well developed. But despite that, there's very limited guidance on what to actually do when a pregnant person has alcohol use disorder, how to manage it, what treatments to consider, and how to support recovery safely. And that gap really highlights how clinical practice has outpaced the evidence base, leaving clinicians to navigate these decisions without much formal direction. Looking ahead, there are three clear next steps. First, clinical practice guidelines need to place greater emphasis on shared decision making, acknowledging the uncertainties we just discussed, and ensuring that patients are informed partners in navigating those risks and choices. Second, since there isn't yet a consensus on the use of medications for alcohol use disorder during pregnancy, we really need better guidelines on what works best psychosocially during this period, how to support patients, which psychosocial interventions to use, and how to tailor them for pregnancy. And third, we really need to strengthen the evidence base for medication treatment of alcohol use disorder in pregnancy. This means both prospective research and systematic evaluation of outcomes among people who continue on MAUD during pregnancy so that future guidelines can move from cautious ambiguity towards concrete evidence informed recommendations. Ultimately, we still have much to learn about how to best treat alcohol use disorder during pregnancy, and closing that gap will be essential to improving outcomes for both patients and their children. I want to express my sincere thanks to my co-authors, especially to Dr. Shu and Dr. Martin for their guidance and mentorship, and to Emily Bassett for being such an incredible partner throughout this project. And I also wanted to acknowledge the grants that supported this work that are listed here on this slide. These are my references. And with that, thank you so much for listening, and I'd be happy to take any questions.
Thank you so much, Caroline. It was so great to see all the results of this great work. So we'll open it up now for any questions, clarifications, or discussion points that people would like. Please feel free to raise your hand if you'd like to speak up, or place your questions in the chat and I will moderate it. Just a reminder, this will be recorded and we will be posting this on my lab's YouTube station, so you will be able to access this presentation after the fact. And I'm going to start with Chuck, who has his hand raised.
Hey, thank you very much for your work in this area. Very important stuff. I have a question for you related to monitoring alcohol use during pregnancy. Um, Generally, we rely upon patients to tell us if they're continuing to drink. Was there anything in the guidelines related to methodologies for monitoring alcohol consumption?
That's a good question. The main one that comes to mind was one of the guidelines specifically said to ask multiple times throughout pregnancy about alcohol use, but I can't think of anything off the top of my head in terms of anything more specific than that. I'm not
Well,
sure if Dr. Shu or Dr. Martin, if you have anything to add to that.
Nothing to add to that.
Yeah.
this goes back to the fact, your last point, which is that we really need to expand our knowledge base about alcohol use in pregnancy. More
Absolutely.
research needs to be done in this regard.
Definitely.
Thank you.
Thank you.
I will also just add a side note about the guidelines also, if you saw, did not have a lot of guidance also about reduction of use and kind of, in the big scheme of alcohol use disorder treatment, we're working towards, the drinking levels, right? And reducing the amount, reducing people's drinking levels by the WHO. And that's been linked to a lot of great outcomes. And now we're starting to change how the FDA evaluates treatments, et cetera, which is so great. But pregnant people have been excluded from all of that research that's been fed to the FDA. So unfortunately, we're kind of in a data-free zone with regards to drinking levels. If you want to call it harm reduction, or at least looking at endpoints for new emerging therapeutics, unfortunately, pregnant people have been excluded from those studies. Does anyone else have any questions?
Yeah, this is Jeff.
Yes.
Thanks so much for Caroline for this really great presentation and summary of how frustrating it is to provide care, I think, in this space. I was curious, I mean, if anyone has a grip on sort of national registries, right? I think, right, MAUD in this sort of population is just, the uptake is very low at baseline, right? So women who are eligible, who can get pregnant. And I know that there is a push, I guess, maybe more in psychiatry or others, to sort of report outcomes of folks on acamprosate, naltrexone, et cetera, just to have some type of national data registry. And I'm just curious if anyone is actively looking at that, is aware of it.
Yeah, that sounds amazing. I'm not sure, Dr. Shu, Dr. Martin, are you aware of anything like that?
I think that's part of the reason we got interested in this in the first place. I was just really surprised at how little there is out there. I also see Mishka is on this call, who may have like insights to offer on this too. But like when Caitlin, myself, Caroline, Mishka, like we were working together looking at the guidelines, I was just so surprised by how much real estate on each guideline is occupied by like, sentences after sentences saying like, this is drinking is harmful for a baby, one should not drink. And then there's just not a whole lot of space left for much else.
Hi, thank you so much for this presentation. Jess, I wonder, or, sort of for anyone else who is familiar, I wonder if Epic Cosmos might be something that could be utilized in so much as it's still with the, sort of healthy dose of recognizing that it is, sort of a natural EMR documentation. And so in whatever limitations, sort of screening data regarding alcohol use is systematically incorporated. But it could at least potentially, from a space of being able to connect prescriptions and refills, potentially connect through to birth outcomes in a meaningful way in the absence of a more robust registry.
Caitlin, do you want to give that a stab?
Yes, we have, I don't know what you want me to say, Kevin. We want to do that.
Great.
Yeah, I mean, we've been starting to do some work on this, and I don't know how much detail, Caitlin, we should go into to not bore people in this. But as Caroline was saying, like part of the problem is people are saying like there's no data. And one important thing I wanted to zero in on that Caroline brought up at the end of her talk was like the guidelines themselves were actually pretty good. They did, Caroline and Emily did these really extensive guideline quality assessments that took like, I don't know, a month plus, just pages and pages and pages of assessments. And they were mostly very solid guidelines. And some of them were like 200, the ones in Canada were like 250 pages long. So it's just interesting, like the guidelines about addressing SUD weren't terrible, a lot of them, but still there's just like nothing there about what to do with the medications and whether they're safe or effective.
Chuck, you're muted.
I had developed a data collection form for a registry for naltrexone and never followed through. I didn't even get to the point of submitting a grant application. But if you guys are interested in looking at the form that I developed, I'd be happy to send it to you. So I've been interested in the subject of alcohol for quite a while. We had also looked at monitoring people during pregnancy with ethanol sulfate, PEth, phosphatidylethanol, and ethyl glucuronide and ethyl sulfate. So there are some ways of monitoring this that aren't used very much, and I'm not really sure why when I reviewed the literature on it. But anyway, I certainly welcome anyone who's interested in pursuing alcohol research in pregnancy. Thank you.
Yeah, that sounds amazing. Thank you.
Chuck, I think it's really interesting. Your question of like, right, essentially more toxicology testing is so complicated. I've had, just thinking clinically, of child welfare agencies or others sort of ask if we keep track of it and if we measure it and if we quantitatively check, right? And it's sort of one of the substances that isn't readily checked for in sort of the standard panels, and we have drawn the line in our clinic that we're not gonna start to look for it. I think in this space it feels very complicated. I do think though, for research purposes, right, and to evaluate efficacy, there's certainly a lot of really interesting stuff there. I think again the question is, how would it change management, right? And do you get the same information from the sort of the questioning and screening? So yeah, it's an interesting, sticky place.
I'm just putting in the chat, PCSS MAUD recently released some online modules that are focused on AUD treatment and in pregnancy and breastfeeding that went live this summer. So it's the first provider-facing training that I know of that's focused on AUD treatments in pregnancy, including medications. And then within that, they also have a good review of the current research that it does exist with regarding what we do have so far on medications for alcohol use disorder, kind of going after some of these questions so far. So I'm putting the chats in the putting them in the chat right now. The first link has the online modules, and the second one, if you scroll down, there's like an infographic brochure that has a list of some of the existing research. So feel free to use that and download that if you're trying to. For me, I'm using it to teach my fellows and my med students, just like some type of centralized place about alcohol use disorder and pregnancy. Does anyone else have any other questions or thoughts or discussion?
I'm curious if people talked about, sorry, I'm really talkative today, but curious if people talked about disulfiram at all. I think it's this very interesting one, right, which I was always taught it is a hard stop, right? in pregnancy, and recently talked with some MFMs who, maybe like challenged that. And I'm just curious, sort of others, if you found anything in the guidelines or what's out there.
From what I remember, that is what we saw in most of the guidelines was, kind of a little more iffy about acamprosate and naltrexone, but kind of hard stop. We do not recommend disulfiram for pretty much all of them.
Yeah, and I can say that we recently did a preliminary analysis of like the number of people who were taking medications before they became pregnant and followed folks through to see like how many people were still on the meds by the time they delivered. And if I remember correctly, the number of folks on disulfiram may be like under 5. And this was like tens of thousands of people nationally.
Yeah, in the MAUD modules, really we only cited some preclinical data and then like one case series that had been published. And according to that, the general recommended based on this one case series that we have, went along with what the guidelines currently say, which is focused on naltrexone and acamprosate. But you bring up a very good point, Jess. Anyone else have any other questions or points for discussion? This has been great. And thank you for the links that have been put in the chat too. These are great resources. I appreciate it. Well, awesome. Well, we are going to go ahead and stop here, but thank you so much, Caroline. That was really great. I really appreciate that you bringing together everything in such a nice, succinct way for us to capture this preliminary data. Just as a reminder, we do have our November, I think I'm sharing the right screen, Journal Club coming up on November 21st at 1 p.m. Eastern Standard Time. So I will send out a calendar invite soon, but please mark your calendars for our next presentation that will be focused on methadone stabilization in pregnancy. And I will send out the recording along with some of the links, yes, with the resources that were shared during the presentation today. Thank you for asking about that. Okay, great. Well, thank you everyone for joining.
Hey, Caitlin.
Hey, Mel.
Random update since